Welcome to the Australian Dental Council 2026 Explainer podcast.
Imagine, just for a moment, waking up in an emergency room after like a really high-speed car accident.
Yeah, and the trauma is so severe that your entire upper jaw has actually physically detached from the base of your skull.
Right. I mean, how does a surgical team even begin to put you back together after something like that?
Or, on a totally different scale.
Hmm?
How does a surgeon operate just millimeters away from the main nerve of your face without leaving you, well, permanently numb?
It's incredible. If you're joining us today, you are stepping into this really profound intersection of structural engineering, highly precise anatomy, and just amazing human resilience.
Absolutely. Our mission for this deep dive is to explore the incredibly complex, really high-stakes world of oral and maxillofacial surgery.
And to do this, we're unpacking a really foundational clinical text, which is the 6th edition of Principles of Oral and Maxillofacial Surgery.
Right, edited by U.J. Moore. And it's such a unique medical discipline, isn't it?
Oh, truly. What's fascinating here is the historical context that this discipline actually emerged from.
Yeah, I loved that part.
Right. In the foreword to the very first edition of this text, they describe this operative area as a medical no man's land.
A no man's land. That is such a striking phrase.
It really is. Historically, it was this territory that was, partly claimed by the general surgeon and partly claimed by the dental surgeon.
But fully mastered by neither of them.
Exactly.
Which honestly makes perfect anatomical sense.
Oh,
I mean, the
yeah.
face, the jaws, the mouth, they represent this incredibly dense geographical border.
Yeah, where dentistry and traditional systemic medicine basically collide.
Right.
Over the decades, it evolved into this highly specialized surgical branch that carries just immense dual responsibilities.
So for the medical and dental students listening to this, or, healthcare policy observers, or even patients,
Yeah.
what's the main takeaway here?
Well, the core takeaway from this foundational material is that possessing sheer technical surgical skill, that's only half the battle.
Right, the manual dexterity part.
Yeah. That physical skill must be matched with rigorous physician-level diagnostic decision-making and a really comprehensive assessment of the total patient.
Okay, so let's unpack this idea of total patient assessment. Because the first major theme that becomes abundantly clear in the text is that before a surgeon ever picks up a scalpel, they have to act as an internal medicine physician.
They really do. The mouth does not exist in a vacuum.
No, it's deeply dynamically integrated with the rest of the body's systems.
Exactly. And the clinical reality is that systemic conditions drastically alter the surgical landscape.
So an oral surgeon has to deeply understand a patient's entire medical background before any intervention.
Absolutely. Take hypertension, for example.
Yeah.
Chronically high blood pressure.
Which might seem like a general physician's problem, right?
Right. But in the operating chair, that increased vascular pressure translates to a severe risk of catastrophic postoperative bleeding.
Oh, wow.
Or consider diabetes mellitus.
Right, because diabetes isn't just about blood sugar. I mean, it physically alters the microvascular system.
Precisely.
It actually thickens the walls of the tiniest blood vessels, the capillaries, which means white blood cells and oxygen can't reach the surgical site efficiently.
Yeah, and that directly impedes how tissues heal. It just skyrockets the risk of a post-surgical infection.
So the systemic physiology completely dictates the local surgical outcome.
It really does. And if we connect this to the bigger picture of, skeletal health, we look at conditions like Paget's disease.
Okay, yeah.
This is a chronic condition that disrupts the normal biological cycle of bone renewal, so it causes bones to become enlarged and deformed.
And in the jaw, Paget's disease can trigger this phenomenon known as hypercementosis.
Yes.
I found the mechanics of this staggering, honestly. Basically, the cementum, which is that calcified, bony substance covering the root of a tooth, it just goes into overdrive, right?
Yeah, it completely overgrows. The tooth root effectively fuses to the surrounding jawbone in this thick, irregular, bulbous mass.
Wow.
So what looks on the surface like, a standard routine tooth extraction suddenly becomes this incredibly grueling, complex surgical extraction.
Requiring massive bone removal.
Exactly.
That makes you think of an analogy. A maxillofacial surgeon is essentially like a structural engineer who is also forced to act as the building's lead electrician and plumber.
I like that. That's a very apt way to conceptualize it.
Right. Because you can't just go in and knock down a wall, in this case, extract a tooth, or reshape a jawbone without knowing exactly how the electrical wiring and the plumbing are running through the entire building.
The nervous and cardiovascular systems, yeah.
Exactly.
And because they are responsible for the entire building, surgeons must be prepared for the entire building to experience a sudden systemic failure.
Right.
The specialty has developed these uncompromising, strict protocols for medical emergencies in the clinical setting.
Because things go wrong.
They do. Students are trained to handle everything from sudden anaphylactic shock triggered by an anesthetic all the way to full cardiac arrest.
I want to push back on that scenario for a second, though. I mean, if a patient goes in a dental chair, the clinician doesn't have an entire hospital ER team standing right behind them.
No, they don't.
So how do they avoid panicking and actually manage that chaos effectively?
Well, they rely on algorithmic, drilled responses, specifically the ABCDE approach.
Okay, what does that stand for?
It stands for airway, breathing, circulation, disability, and exposure.
Got it.
It's a rapid, systematic method designed to assess and treat life-threatening conditions in order of immediate lethality.
So first, airway.
Right. Is there a physical obstruction, like a swab or severe swelling blocking the throat?
Okay.
Then breathing. Is the chest actively rising and falling?
And then circulation.
Exactly.
Right.
Is there a palpable pulse and adequate blood pressure? It basically removes the panic by providing this rigid checklist.
That makes a lot of sense.
And modern operating rooms are also equipped with specific emergency pharmaceutical kits and automated external defibrillators, AEDs.
There was one specific high-stakes warning in the text regarding cardiac events that really stood out to me. It was about agonal gasps.
Oh, yes. That is crucial.
Clinicians are explicitly warned not to mistake these gasps for normal breathing. Can you explain the physiological mechanism there? Like, why is that distinction a matter of life and death?
It is a vital clinical distinction. So in the first few minutes after a sudden cardiac arrest, the heart has stopped pumping, right?
Right.
But the brainstem, the primitive part of the brain, it may still be firing off these desperate, erratic signals to the respiratory muscles.
Oh, wow.
Yeah. And this causes sporadic, heavy gasping reflexes. Those are agonal gasps.
That they are actual breaths.
No, they are mechanically ineffective. There is no actual oxygen exchange happening in the lungs.
I see.
So if a clinician sees a chest heave and mistakes an agonal gasp for a normal breath, they might assume the patient is just unconscious.
And then they delay starting CPR.
Exactly. And the clinical directive is absolute. If a patient is unresponsive and only exhibits these gasps, you treat it as a full cardiac arrest and begin CPR immediately.
Wow. So the stakes are incredibly high before the physical surgery begins.
Very high.
But let's assume the patient is medically cleared, the systemic issues are managed, and the physical operation commences.
Okay.
Here's where it gets really interesting to me. How does a surgeon operate on one of the most delicate, nerve-dense, highly vascular areas of the human body?
Well, they do it by strictly adhering to a core philosophy called the principle of minimal damage.
Which, I mean, sounds like common sense. Obviously, a surgeon shouldn't cause unnecessary damage, right?
You would think so, but the actual application of this principle seems deeply counterintuitive.
How so?
Well, inexperienced surgeons often suffer from tunnel vision. They focus entirely on the pathology like the impacted tooth or the cystic lesion or the bone tumor they are trying to eradicate.
Yeah, you get the bad thing out.
Exactly. But the principle of minimal damage mandates this psychological shift. The surgeon's primary focus must actually be on the preservation of the surrounding tissues that are left behind.
Let me challenge the mechanics of this, though. How exactly do you cut through the mandible or the maxilla, which is notoriously dense, mineralized tissue, without destroying the surrounding microscopic blood supply or the fragile soft tissue?
It's tough.
Because you can't just go in with a medieval hammer and chisel and hope for the best.
Well, historically, chisels and mallets were actually the primary tools.
Wait, really?
Oh, yeah. But the clinical reality today relies on advanced biomechanics. Access to bone is now largely gained using high-speed rotary instruments,
Like drills.
specifically tungsten carbide burrs. But the critical non-negotiable element here is that these high-speed drills must be used with copious, continuous, sterile water irrigation.
To act as a thermodynamic coolant.
Exactly. Because bone is a living, breathing tissue matrix. It's populated by cells called osteocytes. If a drill operates dry, the friction generates immense heat. That heat literally boils the fluid within the bone matrix.
Oh, that sounds awful.
It causes thermal necrosis. The bone cells literally die from the burn.
And dead bone doesn't heal.
Right. dead necrotic bone cannot heal. It becomes the sequestered breeding ground for severe infection. So the continuous water flow prevents that critical heat buildup.
That makes total sense.
We also see the use of piezoelectric surgery now. Piezo saws use ultrasonic microvibrations to cut.
Wait, how does ultrasound cut bone but spare a nerve?
It utilizes the cavitation effect. The ultrasonic frequencies are specifically tuned to shatter the dense crystalline structure of mineralized tissue, like bone.
Okay.
But when the vibrating tip contacts soft, elastic tissue, like a delicate nerve bundle or a major blood vessel, that tissue simply absorbs the vibration and bounces back completely unharmed.
That is amazing.
It really is. It allows for a staggering level of surgical precision.
And that level of precision brings us to how they actually access the underlying jawbone in the first place.
All right.
Because you have to bypass the gums,
Right.
which requires creating surgical flaps.
Yes, specifically the mucoperiosteal flap. The surgeon incises the soft tissue and peels it back to expose the bone.
But the geometric design of that flap is an exacting science, isn't it?
Absolutely. The incision lines must never cut across the primary blood vessels feeding that specific section of tissue.
Because the blood supply generally runs from the base of the gums up toward the teeth.
Exactly.
So if you design a flap where the base is narrower than the top, you've just severed the anatomical highways carrying oxygen to the tissue you're pulling back.
Precisely. And if you compromise that vascular supply, the edges of the flap will literally slough off.
Just fall apart.
Yeah, the tissue undergoes necrosis and dies from oxygen starvation. And then the patient's healing is severely compromised.
So what's the solution?
The surgeon must engineer an incision that maintains a broad, wide base that ensures the tissues left behind remain fully vascularized and viable.
You know, this all sounds incredibly abstract and purely clinical, but it actually affects millions of people every single day.
It really does.
If you, the listener, have ever considered getting a dental implant to replace a missing tooth, that high-speed drill, that cold water, and the geometry of that surgical flap are exactly what dictates whether your new implant stays firmly in your jaw or fails completely.
That's a perfect real-world connection. The success of an implant relies on a physiological process called osseointegration.
Right.
It is the direct structural and microscopic connection between living, healthy bone and the load-bearing surface of a titanium implant.
But osseointegration is biologically impossible if the host bone was thermally damaged, right?
Exactly. If it was crushed or deprived of blood supply during the initial tooth extraction, it won't work. The surgeon's strict adherence to the principle of minimal damage months earlier is the sole deciding factor in the success of your prosthetic tooth today.
Wow. So the principle of minimal damage makes a single dental implant possible. But what happens when the damage has already been done for you, like massively, in the aftermath of a catastrophic injury?
That changes everything.
Let's look at how this specialty restores fundamental function and human identity when facing trauma, tumors, and severe deformity.
Right. When we move into the realm of maxillofacial trauma, reconstructive oncology, and orthognathic deformity, the scale and gravity of the surgery change dramatically.
So let's begin with major trauma, which is typically the result of what? Severe road traffic accidents.
Yeah, car accidents, interpersonal violence, or major industrial falls.
The literature goes into intense detail on the categorization of facial fractures. The classification that really paints a visceral, alarming picture is the Lefort fractures.
Oh, definitely. René Lefort was a French surgeon who basically mapped out the classic structural lines of weakness in the human facial skeleton. A Lefort fracture, particularly a Lefort 2 or 3, essentially involves the middle third of the face, so the maxilla, the nasal bones, and sometimes the orbital floors beneath the eyes.
Right.
That entire middle section completely detaches from the rigid base of the skull. The entire midface becomes a mobile, floating segment.
A floating midface.
Yeah.
In a trauma situation of that magnitude, the facial structure is obviously devastated. I would assume the immediate priority is to start resetting those broken bones.
You would think so, but no. The clinical protocols dictate a very different priority.
Okay.
The absolute first priority in facial trauma is never the bones. It is securing the airway and arresting massive hemorrhage.
Because of the bleeding.
Right. Maxillofacial trauma can cause profuse bleeding into the throat, and the soft tissues of the mouth and neck will swell massively. That rapidly occludes the patient's airway.
And the patient has to be what's called hemodynamically stable before bone reconstruction begins. Can you unpack that term for us?
Sure. Being hemodynamically stable means the patient's cardiovascular system is functioning well enough to sustain life.
Okay.
They have adequate blood pressure, and oxygenated blood is actively perfusing vital organs like the brain, the heart, and the kidneys.
Only once that's secured, then you move to the bones.
Exactly. Once the airway is permanently secured and the patient is hemodynamically stable, the surgical team shifts focus to restoring the structural integrity of the crushed facial architecture.
And how is that structural integrity actually rebuilt so the patient can function again?
Today, it is largely achieved through rigid internal fixation.
I mean, plates and screws.
Yes. Surgeons use highly specialized, miniaturized titanium plates and screws called mini plates.
Because the jaw is so strong, right?
Incredibly strong. The jaw exerts hundreds of pounds of mechanical force when chewing. Therefore, the broken bone fragments must be rigidly anchored together so they do not experience micromovements during the month-long healing process.
What about if they have no teeth to guide the bite?
In those complex cases, they utilize gunning splints. These are specialized dentures wired into the jaws to help align the skeletal structures when a patient has lost their teeth, guiding the bones to heal in their correct, original anatomical position.
That is the response to sudden, violent trauma. But the specialty also battles these insidious, creeping threats like oral cancer,
Yes, unfortunately.
and managing squamous cell carcinomas of the head and neck requires a massive, coordinated medical response.
It is the definition of a multidisciplinary effort. The surgical team works in tight coordination with oncologists, radiation specialists, speech therapists, dietitians, and restorative prosthodontists.
And the clinical goal here is twofold and seems deeply contradictory.
It is. The surgeon must aggressively and radically eliminate the malignant tumor, but they must simultaneously reconstruct the devastating anatomical defect left behind by the excision.
And eliminating the tumor isn't isolated to just cutting a lesion out of the mouth. The clinical protocols detail the absolute necessity of neck dissections.
Yes, because oral cancers are highly aggressive and frequently metastasize.
Meaning they spread.
Exactly. They spread through the lymphatic system to the lymph nodes hidden within the neck. A neck dissection is a grueling procedure that involves systematically stripping out those cancerous lymph nodes.
And the neck is essentially a minefield of vital vessels. You're navigating around the jugular vein, the carotid artery, the vagus nerve.
It's incredibly tense. The surgeon is meticulously clearing out diseased lymphatic tissue while purposefully avoiding the critical lifelines that supply blood to the brain and control heart rate.
And sometimes they have to sacrifice healthy tissue.
Sadly, yes.
Yeah.
Sometimes the cancer has invaded so deeply that adjacent muscles or sensory nerves must be permanently sacrificed to ensure the margins are clear of disease.
There is a really sobering reality regarding maxillary tumors located in the upper jaw and the roof of the mouth.
Very sobering.
Removing them surgically can create a direct physical communication, a literal gaping hole between the oral cavity and the nasal cavity.
Which is an utterly catastrophic loss of quality of life for a patient.
I can't even imagine.
Without that hard palate acting as a solid barrier between the mouth and the nose, every time the patient tries to eat or drink, food and liquid regurgitate directly up into the nasal cavity.
And speech would be affected too, right?
Absolutely. Normal speech becomes impossible. It becomes incredibly hypernasal and largely unintelligible because the patient cannot pressurize the air in their mouth.
But this is where the intersection of engineering and medicine truly shines. Restorative dentists step in with a prosthetic device called an obturator.
Yes, the obturator. It's a highly specialized, custom-engineered prosthetic appliance.
How does it work?
It physically plugs the surgical defect in the palate. By perfectly sealing that unnatural communication between the oral and nasal cavities, the obturator instantly restores the physics of the mouth.
Wow.
It allows the patient to create the negative pressure required to swallow food normally and restores the precise airflow dynamics required to articulate clear, intelligible speech.
It's mechanical engineering solving a biological crisis. We see a similar level of engineering in orthognathic surgery, which focuses on the correction of severe facial deformities.
Right.
We're talking about profound skeletal jaw disproportion, like an extreme debilitating underbite, or reconstructing the structural aftermath of a congenital cleft palate.
In these severe cases, traditional orthodontics like braces, they cannot fix the patient's bite.
Because the teeth aren't the issue.
Exactly. The teeth are fine. It's the underlying skeletal foundations that are physically mismatched. The surgeon must physically cut the jawbones free and reposition them.
And a prime, highly complex example of this is the sagittal split osteotomy for the lower jaw.
The mandible, yes.
Okay, let's unpack this specific procedure because the localized anatomy makes it incredibly precarious.
It really does. The procedure involves deliberately splitting the lower jawbone lengthwise, right down sagittal plane, separating the dense outer cortical bone from the softer inner bone.
Okay.
This allows the surgeon to essentially slide the tooth-bearing section of the jaw forward or backward to perfectly align the bite while keeping the jaw joints in their sockets.
And then they just plate it together.
Yeah, the overlapping bone edges are then plated together to heal.
But here is the massive anatomical risk.
Yeah.
You have the inferior alveolar nerve, a thick nerve trunk, which provides all the physical sensation to your lower lip, your chin, and your lower teeth, running inside a hollow canal directly through the middle of that exact same lower jawbone.
Exactly.
You are physically splitting the bone that houses the nerve.
Which is why the technical precision required is immense. Even with flawless surgical execution, merely manipulating the bone, encasing that nerve, or stretching it as you slide the jaw forward carries a profound neurological risk.
The nerve can get damaged.
The nerve can become bruised or compressed. While the patient wakes up with a perfectly aligned bite and a corrected facial profile, they face a significant risk of temporary or sometimes permanent sensory loss to their lower lip and chin.
It is a profound trade-off.
It is, and patients must be exhaustively counseled on these neurological risks beforehand.
It really highlights the high-wire balancing act of this specialty. Which brings us to a highly perplexing, often frustrating area of clinical practice.
Oh, chronic pain.
Yes. Sometimes a patient comes into the clinic, the radiographic x-rays are totally clean, the skeletal anatomy looks structurally perfect, but the patient is suffering from immense, debilitating pain.
This represents one of the most challenging diagnostic arenas for any surgeon. Chronic orofacial pain is a labyrinth.
So how do you even navigate that?
Well, we can differentiate between several conditions, but let's contrast two deeply distinct ones: trigeminal neuralgia and temporomandibular disorders, commonly known as TMDs.
Let's start with trigeminal neuralgia. This is not a bone or a joint problem at all, right?
Correct. Trigeminal neuralgia is fundamentally a neurovascular issue. It is most often caused by vascular compression.
Meaning a blood vessel is pressing on something.
Exactly. Deep inside the skull, a rogue blood vessel, usually an artery, physically loops around and pulses against the root of the trigeminal nerve. And that's the main sensory nerve of the face.
It's like a live electrical wire, where the rubber insulation has been rubbed off.
That is exactly what is happening on a microscopic level.
Yeah.
The constant pulsating of the artery wears down the myelin sheath, the protective biological insulation surrounding the nerve fibers.
And without that insulation,
The nerve short circuits. A light breeze against the cheek or chewing a soft piece of food triggers sudden, severe, excruciating electric shock-like facial pain.
that sounds horrific. So how do they treat that?
The treatment often requires neurological medication or delicate neurosurgery to physically place a tiny Teflon sponge between the artery and the nerve. It is entirely unrelated to dental health.
But then you have TMDs, which actually affect the temporomandibular joint, the jaw joint itself, and the surrounding masticatory muscles.
Right.
And the clinical guidelines are extremely prescriptive here. They highly emphasize starting with conservative reversible therapy first. Things like soft acrylic bite splints, targeted physical therapy, or even cognitive behavioral therapy to manage stress-induced clenching.
Yes, the clinical doctrine is incredibly adamant about conservative management first, and it is crucial to understand why.
And that's exactly what I want to challenge. If a patient is suffering from chronic, daily jaw pain, and it's a localized physical joint, why wouldn't the surgeon just go in and fix the joint surgically right away?
I get that question a lot.
I mean, if someone has a bad knee, they get knee surgery.
Yeah.
Why bother with soft splints and physical therapy for a jaw?
Because the temporomandibular joint is not a simple hinge like a knee or a ball and socket like a hip.
What is it then?
It is a highly complex dual-action joint that must simultaneously rotate and translate, meaning slide forward, just to let you open your mouth.
Oh, I see.
Irreversible surgical interventions on this joint are drastic, and they are rarely the best initial step. The vast majority of TMD cases are actually muscular in origin, caused by spasms in the chewing muscles.
Or inflammation, right?
Exactly. Completely benign, self-limiting joint inflammation that responds beautifully to rest, physical therapy, and conservative management.
So when do they actually commit to operating on the joint?
Open joint surgery is strictly reserved for severe, degenerative, and irreversible pathology.
Like what?
We are talking about procedures like eminectomies, where the surgeon physically shaves down the bony ridge of the joint to prevent a chronically dislocating jaw from getting stuck open.
That sounds intense.
It is, or in the most extreme cases, total joint replacement.
A total replacement of the jaw joints.
Yeah, this is utilized when advanced osteoarthritis or an autoimmune disease like rheumatoid arthritis has physically destroyed the cartilage and the bone of the joint.
What do they replace it with?
In those end-stage scenarios, they might use alloplastic joints, which are custom-machined artificial implants made of titanium and high-density polymers.
Okay.
Or they might utilize a costochondral graft.
A costochondral graft is where they harvest a piece of the patient's own rib to rebuild the jaw.
Right. Yes. They take a segment of the rib where the bone meets the cartilage.
Why that specific spot?
Because that natural cartilage cap excellently mimics the natural anatomy of the jaw joint.
But harvesting a rib to rebuild a face? That is a massive physiological toll.
It is. It is the absolute last resort.
So the overarching philosophy of the specialty seems to be, do not alter the anatomy permanently unless the anatomy is permanently failing.
Exactly. It is the ultimate manifestation of the principle of minimal damage applied to diagnostic treatment planning.
It is truly remarkable. We've traversed from managing the microscopic blood supply of a tiny surgical flap to the brutal biomechanics of titanium plates, to the intricate engineering of a rib graft replacing a shattered jaw joint.
It's a vast field.
If we synthesize all of this, what does this deep dive into these clinical foundations really tell us? To me, it demonstrates that oral and maxillofacial surgery isn't just a collection of advanced dental procedures.
Not at all.
It is a profound, demanding medical discipline. These surgeons are tasked with rebuilding the literal face we present to the world. They aren't just restoring the mechanical ability to chew food. They are restoring a patient's fundamental dignity, their ability to communicate, and ultimately, their identity.
It is a profound, life-altering responsibility. And as a final thought to leave you with, consider the future trajectory of this reconstructive field.
Where is it heading?
The clinical texts are increasingly focused on a phenomenon called guided bone regeneration.
Right, this is where surgeons use specialized barrier membranes during a procedure.
Yes. You see, the human body utilizes different cells that replicate and heal at vastly different rates.
Okay.
Soft tissue cells, known as fibroblasts, migrate and reproduce incredibly quickly to close a wound. But bone-forming cells, osteoblasts, are heavily specialized and move much slower.
So it's a race.
Exactly. If a surgeon leaves a massive bony defect empty, the fast-moving soft tissue will rapidly migrate in and fill the void long before the bone cells ever have a chance to build a rigid structure.
It's exactly like aggressive weeds taking over a patch of garden soil before the slow-growing vegetable seeds ever have a chance to sprout.
That's a perfect analogy. Precisely. So to combat this, surgeons place a biocompatible barrier membrane over the bony defect.
And that acts as a shield.
Yes. This membrane physically blocks the fast-growing fibroblasts from entering the space. It creates a protected, isolated sanctuary beneath it.
Which gives the bone cells time to work.
Exactly. It forces the body to prioritize the slow, methodical growth of new, solid bone.
It's essentially cellular manipulation at the surgical site.
It absolutely is. And it raises an incredible, provocative question for the future of medicine.
I'm intrigued.
As our understanding of cellular manipulation, biomaterials, and genetic signaling advances, will the future of maxillofacial surgery rely less on titanium plates, metal screws, and harvesting ribs?
Wow.
Will the ultimate evolution of the principle of minimal damage be stepping back and simply programming the body's own cells to seamlessly regrow its shattered architecture?
That is a staggeringly complex, amazing thought to leave on. For more insights into the future of reconstructive medicine, please subscribe and share this update.